Congratulations. Your Facebook status updates under cost better.
What? No, that's not right. Did you switch your status before she did? Speaking as an expert, way to look at me.
Seriously? You reversed the early 2 weeks?
Bold. It's not bold, it's a mistake. I didn't change my status.
Well, but who did it?
I had no choice. He cried in front of her. You hacked my Facebook account? Oh, it's hardly hacking when you use the same password for everything, Kal-El. Are you insane? Now she's going to think I'm desperate. You've destroyed this relationship. And you want to know the worst part is you don't even understand what you did wrong because you can't conceive of something that you are not an expert in. Don't even. I don't want to hear another word out of you. Our men have a relationship with Leonard.
Cristiano Ronaldo shocked the world when he exposed his coach.
Popcorn again, salt, oil, everything. Salt, oil again. Salt, oil together. That was the biggest thing I've ever seen in my life. That's not going to happen. Never know, though. We could survive the fall. Start with our rainbow sprinkles. Want to add our popcorn. We got some coconut oil. That's good right there. Last thing we have is some salt. Okay. All right. Okay, now we start to stir it. Then we heat up the oil. So we gotta wait for a couple pops. Then we can cover it, right? Then we can cover it. As long as every kernel is covered in oil, every kernel oil, we get a pops. You get one. So much oil in here, man. The sprinkles. Yeah, it's turning a little bit red now. Why is it turning into? Why is it getting hard? I think it's actually sort of caramelized on the front one. We're on to something. He was on to something. See, it's sort of black. It's burning. Oh, it's gonna burn. Go! Oh, it's not right under my foot. Got it. Oh, with the lid on. It's gonna cover them in the sprinkle juice. It's gonna caramelize. Okay, keep going, keep going. So slippery in my. How's that happening? I don't understand. Okay, ready? As compared to Korea. They're very experienced. They're fast though. They work hard. They do.
Minute
Chị sắp tiếng.
As compared to your career, they are not that long in the business. This is what I want.
Jadi man. Kalau tambah 5 minit lagi okey kot. 10 minit membuat kan? 15 minit kot. Dia tak manis man, dah okey. Kamu ni tak manis.
on BTS compared to your career?
Assalamualaikum warahmatullahi. Can you hear me?
Yes, Doctor.
Berapa orang?
Yes, Doctor.
How many people? Sorry? Has everyone joined or still waiting for people?
There are still people who haven't joined yet, but the presenters are all here.
How many? Is it everyone? 20, 30 of you? Supposedly?
Not everyone. I think 10.
All right, okay. I think we wait for another minute after that we start. Okay, presenters, if you're ready, we can start.
Can you see the slide?
Yes.
All right. Okay. So assalamualaikum to everyone. So my task is procedure seminar for intubation. My name is Salehin Shaden. So let's go for the indication and contraindication for intubation. For indication, intubation is indicated when back and mask ventilation or continuous positive airway pressure is insufficient, and for prolonged positive pressure ventilation, for direct suctioning of the trachea to maintain and protect the airway, and for diaphragmatic hernia. It is contraindicated if the operator is inexperienced in intubation, perform back and mask ventilation till help arrives. So if the operator himself is inexperienced, it's better to not do intubation. Let's go a bit of anatomy. So we have epiglottis, which is attached to the interior portion of the thyroid cartilage. So epiglottis will allow airflow in and out of the trachea. So it will keep open to allow airflow. But then when swallowing, it will be closed to prevent food from entering the trachea. And we also have the trachea itself, and behind the trachea is the esophagus. So the view down the throat, as we are doing the intubation, we can see the epiglottis on the upper side, epiglottis, and then the vocal cords. Down the vocal cords are the larynx, and then we can also see the esophagus. Okay. So what are the equipments needed? First one is the bag and mask with high oxygen flow, the laryngoscope, blades. So blades, we have straight blade for infants, curved blades for an older child, different sizes also, size 0 for neonates, size 1 for infants, and 2 for children. We have also stylet, but it is optional because usually stylet is just to facilitate the ETT, okay? And we also have the ETT, the endotracheal tube, with different sizes and for different indication. Okay. We also have scissors and adhesive tape, pulse oximeter, ECG monitoring, sedation, suction catheter and device, and also consider some muscle relaxants such as glucuronidine and succinylcholine. So let's go to the procedure. So the first one, we need to position the infant with head in midline and slightly extended, or known as the sniffling position. So as you can see in the picture, the right way is to make sure the glabella and the chin are horizontally aligned and that the neck are open, and make sure the external auditory meatus and the sternal notch are horizontally aligned. So this is the sniffling position, the right way for infant. And then the second step is to continue back and mask ventilation up to 3 minutes if necessary, with 100% oxygen till well saturated. So in newborns, adjust the fraction of inspired oxygen accordingly until the oxygen saturation is satisfactory, which is between 94 to 98%. So the medication used in rapid sequence induction for emergency anesthesia, we consider induction of ketamine. Ketamine is to induce loss of consciousness, but we need to be cautious in patient with raised intracranial pressure. We can also give muscle relaxant if the child still struggling, for example, succinylcholine, a muscle relaxant, also rocuronium. Need to be cautioned with patient. We need to be cautioned because we must be able to back the patient well or have good intubation skills before giving this muscle relaxant. We can also consider sedation, IV midazolam or IV morphine. Okay. So the next procedure is to monitor the child's vital sign continuously throughout the procedure. And then we can start introducing blade between the tongue and the palate with our left hand and advance to the back of the tongue while assistant secures the head. And when we can already see the epiglottis, we need to lift the blade upward and outward to visualize the vocal cords. If there is secretions, we can suck the secretions. And using our right hand, we can insert the endotracheal tube from the right side of the infant's mouth, and we can use a stylet to facilitate the passage. Okay. And then we need to keep the glottis in view and insert the ETT when the vocal cords are open till the desired ETT length while assistant applies the cricoid pressure. And if intubation is not done within 20 seconds, the attempt should be aborted and re-ventilate with bag and mask. Once intubated, we need to remove the laryngoscope and hold the ETT firmly with left hand, connect to the self-inflating bag and positive pressure ventilation. Then we can confirm the ETT position by looking at the chest expansion, listen to the lungs at entry and also the stomach. The next procedure is we need to secure the ETT with the adhesive tape, connect ETT to the ventilator or resuscitation bag, insert orogastric tube to decompress the stomach bag, and we need to check for a chest radiograph. Okay, so what are the complications of intubation? The first one is esophageal intubation, and then right lung intubation. We can cause trauma to the upper airway. We can also cause pneumothorax, subglottic stenosis, and relative contraindication for succinylcholine such as hyperkalemia and also malignant hyperthermia. So I think we can watch this video to better visualize the steps.
In a cross-sectional view with the patient prone, the key anatomical landmarks are noted. A laryngoscope is used to
Can you hear the sound? All right.
accomplish the intubation. The laryngoscope has a removable metal blade. Laryngoscope blades come in a variety of sizes and shapes to accommodate variations in the throat and neck anatomy from patient to patient. Prior to insertion of the laryngoscope, the head of the patient is extended slightly on the cervical spine, pushing the chin upward and reducing the angle between the oropharynx and the upper airway. The blade of the laryngoscope is inserted to depress the tongue and open the epiglottis. It is critical that the blade chosen be of an appropriate shape and size for a given patient, so that the tip of the blade can reach the hypoepiglottic ligament at the base of the epiglottis. When pressure is applied to the ligament as shown here, the epiglottis opens fully. The endotracheal tube is now inserted. Typically, a length of heavy but flexible wire is inserted through the endotracheal tube to conform to the shape of the airway and assist the operator in insertion. The endotracheal tube is inserted so that the inflatable cuff is pushed beyond the vocal cords. The laryngoscope is now withdrawn. The cuff on the laryngoscope lies beyond the vocal cords in the upper trachea, as noted here. When the cuff is inflated with air, it anchors the endotracheal tube within the trachea and also seals the trachea against the possibility of aspiration. As mentioned previously, this is what is meant by a protected airway. The patient is now ready for ventilation with either an ambu bag or a ventilator machine. Once ventilation has begun, the lungs are auscultated to ensure airflow and eliminate the possibility of an esophageal intubation. Please see my animation on esophageal intubation in the resuscitation library for more information. In a cross-sectional view with the patient prone, the
Okay, I think that's all for my part. Is there any question?
We leave the question session to the end presentation. Yes,
Sorry.
continue. We will leave the
Oh, okay.
Q&A session to the end, right? Continue with the
Okay.
rest.
Okay, thank you, Doctor.
Doctor, can I continue the session after Azan?
All right, okay. Kita break for the continue. Right.
Okay, Assalamualaikum. My name is Muhammad Ashraf Muhammad Nudin, and I will present about the test. You guys can hear me?
Yes.
Okay, thank you. For the introduction, this is the peak flow test. It is a simple and quick test to measure the speed of exhaled air, and it is done by instructing the patient blowing out air as hard as fast as possible. It means the peak flow meter is used to measure the rate of exhaled air. So the device that we use is a peak flow meter. The one at the right side. It is a portable, cheap, and easy handheld device that measure peak expiratory flow rate, which can call PEFR. So this device is very in size and the price. Uh, okay, so what is the indication to use this peak flow meter? It is commonly to detect and monitor patient with COPD, to measure the lung function and to detect other respiratory problem such as chronic bronchitis and emphysema. And lastly, it is commonly used for monitoring asthma. Uh, Also can be used for monitoring asthma, to monitor lung function, response to treatment, to determine the severity of asthma attack, and to assess response to treatment during asthma attack. So in this using this device, there's a complication. Usually the patient will affect dizziness and also can feel a light headache, shortness of breath, coughing, wheezing, and if the peak meter is not sterile enough, uh, they can cause infection too. For the contraindication, actually there's no contraindication because it is a self-use device, and the peak flow is only performed by the patients older than 5 years old. Uh, so this is the equipment we use in the pixelometer. We will refer to in the pediatric, we will refer to the PEFR chart. There are different from boys and girls, and is according to the height of the patient itself. And the right one is the flow meter. So if we can see, there's a marker with the scale, and at the right side they have three colors: the green, yellow, and red. It is for the personal best. So personal best is the highest peak flow measurement achieved, and it is measured when there is no asthma attack or no asthma symptom, and perform three measurement with the same peak flow meter 2 to 4 times daily for 2 to 3 weeks. So personal the personal best is the green zone, the stable one, which the predicted value is 100%, 80 to 100%. The yellow zone, which is at the caution level, when the patient only can exhale 50 to 79%, or the danger or red zone, when the patient only can exhale lower than 50% of the personal best. So this is the methodology to take the peak flow measurement. So first, of course, we have to have the peak flow meter. Usually, in hospital setting, they will provide it like this one. Okay. Second, place the marker the zero or the lowest number. So the next one, we have to ask the patient to stand up, exhale all the air in the lungs, and inhale deeply with the full lung capacity. Next, while holding breath, place the mouthpiece between the teeth and the lip seal. Make sure there is no other air entry between the mouth and the mouthpiece. Next, blow up as hard and as fast as possible. The next one is write down number shown on the and repeat the method uh, 3 times. So we can only take the best as the personal best. Next, I will show the video.
Before each use, make sure the sliding marker is at the bottom of the numbered scale. Stand or sit up straight with your chin slightly lifted and look straight ahead. Keep this position for the entire time. Blow out and empty your lungs as much as possible. Breathe in deeply to completely fill your lungs with air. Put the mouthpiece between your teeth and close your lips tightly. Do not put your tongue on the mouthpiece. Blow out as hard and fast as you can through the mouthpiece. The sliding marker will move up the scale. Look at the number on the meter to see where the marker stopped. Repeat the steps and measure your peak flow 3 times. Record the highest number you reached. Be sure to reset the meter to 0 before each time that you blow into the meter. Keep a record of your peak flow number around the same time each day for 2 weeks while you are feeling well.
I think your mic is muted.
Okay, sorry. So there is some factor that affect reliability of the peak flow measurement. First, not breathing deeply before starting the measurement. Second, not breathing out strongly enough. Third, coughing or sneezing while doing the test. Fourth one is poor seal around the mouthpiece while doing the test. The fifth one is blocking the mouthpiece with the tongue during exhale. And the last one using a different type of brand uh, of the peak flow meter. I think
If we're done, we move on to the next one.
Ya, Assalamualaikum warahmatullahi wabarakatuh. My name is Cikgu Naimah, and tonight I will share about the anthropometry measurement. So before I start, please let me know if my voice is interrupted or my slide is not moving, because right now my Wi-Fi is unstable. Okay. Okay, this is the content of my presentation tonight. Introduction, height measurement, weight measurement, height circumference, and also growth chart. Okay, first let's look into the introduction, which is the
Okay, Bismillahirrahmanirrahim. Okay, Bismillahirrahmanirrahim. So my name is Patricia Huda binti Badru Hisham. So today I would like to share about blood culture and sensitivity. So blood CNS is a laboratory procedure in which a patient's blood is inoculated into bottles containing culture media. It is a widely used diagnostic tool for the detection of bacteria and fungi. So the purpose of blood CNS, or why the doctors order blood CNS, is to first to confirm infectious etiology, and then to identify the etiological agent, and the last one is to guide antimicrobial therapy. Like for example, if the child has suspected of pneumonia or sepsis, we can order to do blood culture for the patient to confirm the etiological agent. Then from that, we can start to guide antimicrobial therapy. Next is the indication. First, if there is clinical suspicion of sepsis, like some signs of sepsis are shock, fever, chills, and tachycardia. And the second one, if there is the risk of endovascular infection like vascular graft infection, infective endocarditis, and intravascular catheter infection. And another indication is local infection, such as pneumonia, meningitis, and septic arthritis. And then blood CNS complications. First is hematoma, which is a collection of blood outside of blood vessel. It is usually caused by a broken blood vessel that happen if we push the needle too far into the vein, and then blood start leaking out of the opening and into the surrounding tissue. So there will be blue or purple discoloration at the venipuncture site, which is indicate the presence of hematoma. And then another complication is fainting. Then infection. So some frequent causes include poor collection techniques and insufficient skin disinfection. And then extravasation injury. Extravasation may occur due to either the cannula pierce the vessel wall or from increased venous pressure that cause leakage around the original venipuncture site. And then next is site selection for blood culture. So some of the preferred site are the dorsum of the non-dominant hand and the median cubital vein in antecubital fossa or other upper extremity blood vessel. And then the last one, foot vein, but foot veins are the last resort for blood culture venipuncture site. And then the prohibited site are veins that proximal to existing IV cannula or areas of bruising. And then how to identify a vein? First, we need to push the vein firmly with an index finger and then slowly release the pressure and the vein will bounce back. And then next is the equipment like apron, sterile glove, tourniquet, blood sampling device with blood culture bottle adapter or we call wing blood collection set, blood culture bottles. For pediatric, there is only one bottle, but for adult, there is two bottles, which is anaerobic and aerobic. And then sharps container, cleaning swab, sterile gauze, sterile plaster, tape, laboratory forms, label, and transportation bag. Then continue with the techniques. So basically the pre-procedure basic. First, as we know, we need to greet the patient, introduce ourselves, explain the procedure, and also gain consent. And then the first technique is to prepare blood collection kit. First, we need to confirm the patient's identity and gather all required materials before starting the process. And also do not use collection bottles beyond their expiration date or has signs of damage or contamination. And then next, we need to prepare bottles for inoculation. First, of course, we need to wash our hands with soap and water, then dry it. And then we need to remove the plastic flip cap from the bottles and then disinfect the septum, allow bottle tops to dry to fully disinfect. And then we start to don gloves and apron. And then the third technique is to prepare venipuncture site. We need to clean with soap and water if the skin is visibly soiled. And then we start to apply a disposable tourniquet, palpate and identify a vein using clean examination glove, cleanse puncture area using appropriate disinfectant, and allow disinfectant to fully evaporate. And then next step is to venipuncture. Attach a wing blood collection set to a collection adapter cap. We must remember to not repalpate the prepared vein before inserting the needle to prevent contamination. And then insert the needle into prepared vein and at 30-degree angle or less, bevel facing upward, and then observe for flashback of blood. And then the next step is for culture blood inoculation. Place the adapter cap over aerobic bottle and press straight down to pierce the septum. Hold the bottle upright below the draw site and add up to 10 milliliter of blood per adult bottle and up to 4 milliliter per pediatric bottle. And then repeat procedure for anaerobic bottle, like I said before, it is for the adult. And then other blood tests, which mean if the blood is being collected for other tests. So we must do blood culture first. And then the last one, to finish the procedure, release the tourniquet and apply gauze, then remove the butterfly needle, discard wing collection kit into sharps container, remove glove and perform hand hygiene, label the bottle carefully and correctly, and we must send blood sample to lab immediately within 2 hours. And of course, we need to thank the patient.
The first step of the procedure is to identify your vein. So we'll be using the right leg. You then need to set up your trolley, ensuring that you have all the correct equipment available. This will include cleaning the top of the blood culture bottle with an appropriate wipe for equipment. The next step is to wash your hands and clean them using a sterile towel and don sterile gloves. The first step is to ensure that the area you're going to be performing is sterile and to put a sterile towel underneath the affected limb. Clean the area where you're going to be performing the cannulation. You should let this dry for 30 seconds, which you can ensure by asking an assistant to run a timer for you. The next step is to cannulate the vein. If you need to repalpate the site, then you need to re-clean the skin. If you have a failed cannulation attempt, then you need to use a new cannula for every attempt. Once you have inserted your cannula, you need to obtain the blood for culture using a sterile needle and syringe. You need to ensure that you have at least 0.5 mils of blood available for an effective blood culture. Insert your sample into the blood culture bottle, which will then be sucked up by vacuum. If you need to leave the cannula in situ, flush it through with an already prepared T-piece and apply Tegaderm. If you're removing the cannula, then ensure that the bleeding has stopped once it has been removed. Print off any necessary blood forms from the computer and send the samples to the lab. Patients.
So I think that's all for blood culture and sensitivity. We pass to the next presenter.
Assalamualaikum warahmatullahi wabarakatuh. My name is Cikgu Naima, and tonight I will be share about the anthropometry measurement. Okay. For introduction, anthropometry is a study of measurement of human body, which taken from Greek words. Anthropo means human and metron means measure. So the importance of anthropometry measurement is to measure nutritional status of pediatric patient, and also it is essential to determine whether the child is thriving or failure to thrive. So the component of anthropometry difference according to the age. For below 2 years old, we measure length, weight, and also head circumference. As we know, for the child below 2 years old, the frontal is not closed yet. So any changes in intracranial pressure will cause microcephaly or macrocephaly. For above 3 years old, we measure height, weight, and also BMI. All right. For height or length measurement, according to depending on the position of the patient. If patient is standing upright, so we call it high. If patient is lying down, recumbent, so we call it as length measurement. So all right, same. We divide, categorize into below 2 years old and also above 2 years old. For below 2 years old or child that unable to stand, we use equipment infantometer, in which the child need to line supine, and the head of the child is put against the fixed headboard, and then we apply gentle pressure on the knees to strengthen the leg. While holding the knees, we pull the footboard towards the child feet. So, and then we got the measurement of the length and we record the length to the nearest 0.1 centimeter. For children above 2 years old who can stand, so we can use equipment stadiometer, in which the technique is we ask the child to stand on the baseboard with feet slightly apart without shoes, and then we pull down the headboard to rest firmly on top of the head and compress the hair, and then we record the height to the nearest 0.1 centimeter. For weight measurement, same as height measurement, we divide according to less than 2 years old and also more than 2 years old. All right, first for less than 2 years old, we have two equipment. First, electronic baby scale, which we undress the child, and then we put the child on the scale and record to the nearest 0.1 kilogram. Another method is use equipment type weighing scale. This technique is used when the child cannot cooperate. So we use this equipment. So the equipment is, we ask the mother first to remove the shoes and step on the scale to be weighed alone first, and then we take the mother weight, and then we reset the scale to 0, and then we give the mother the child to hold, and then the child weight will appear display on the scale. Then we record the child's weight, and then we record the child weight that appears on the display to the nearest 0.1 kilogram. For children above 2 years old, we use equipment weight standing scale, in which we remove the shoes and outer clothing if possible, and then we ask the child to stand still with feet slightly apart and record the weight to the nearest 0.1 kilogram. All right, for head circumference, it is usually done for children below 3 years old because, as we know, children below 3 years old, the frontal nail is not closed yet. So any changes in intracranial pressure can cause significant appearance. Okay, the equipment used for head circumference measurement is non-stretching tape. So the technique is we measure around the head at the widest point. First, we place the end of the tape on middle forehead, and then we wrap around the temporal bone and most posterior portion of occipital bone. And then we measure twice, and then we measure twice until the variation is lesser than 0.5 centimeter. And then we record the measurement to the nearest 0.1 centimeter. All right, for the growth chart, it is a series of percentile curve that illustrate the distribution of selected body measurement in children. Okay, there are several types of growth chart. First, it is WHO growth standard, usually used for children aged 0 to 2 years old. And in Malaysia, we don't have Malaysian growth chart, so we use WHO growth chart. For CDC growth chart, usually it is used for measurement children between 2 years old and above. And then lastly, Fenton growth chart for preterm baby that born less than 37 weeks of gestation. This is the ratio of CDC and WHO. For information, CDC use centile or percentile, while WHO use standard deviation or SD. So one centile equal to 2/3 standard deviation. So meaning that third centile equal to 2 standard deviation. All right. This is the difference between the preterm baby growth chart and also term baby growth chart. Both are gender specific. and both include weight, length, and also head circumference. But in preterm baby, it is measured by weekly increment. Meanwhile, in full-term baby, we measure in monthly increment. And then for preterm baby growth chart, it doesn't include weight for length or BMI. For full-term baby growth chart, we use the BMI but only for above 2 years old. And then for preterm baby growth chart, the growth chart begins at 22 weeks and end at 50 weeks. And the preterm baby growth chart is used in conjunction with term baby growth chart after 40 weeks. All right. So these are the component of growth chart. We have weight for age, length or height for age, BMI for age, and also head circumference. For three first component, they are divided into age and also the gender of the baby. All right, first let's take a look at the weight for age. The picture I attached is weight for age in boys between birth to 2 years old. And then as we can see the chart, the above 3 and 2, which is the red color, indicate the child may have growth problem, and we need to further assess with the BMI for age growth chart. And then for if the measurement of the weight of children is between 2, 0 and also -2, the white color, it indicates the child has normal weight. And then below -2 standard deviation, it indicates underweight, and below -3 standard deviation, it indicates severely underweight. Right, for length or height for age, this is WHO length for age boy birth to 2 years. For if the length or height of the child is above 3 standard deviation, it is very tall. Between 2, 0 and -2, it is normal. Below -2, it is stunted, and below -3, it's severely stunted. Okay, for BMI for age, it is usually BMI is usually used for children above 2 years old. All right, for above 3 standard deviation, it is indicate the child may obese. Above 2 is overweight. Above 1 is possible risk for overweight. 0 and also below -1 is normal BMI. Below -2 is wasted, and below -3 is severely wasted. All right, for head circumference, it is also gender. According to gender, we have boy and also girls, but the picture I attached here is head circumference for girls. All right, the head circumference, as we know, is measured until 36 months or 3 years old. And then the arrow is showed the 50th percentile. All right, for head circumference, if the measurement is lesser than the second percentile, it shows the baby or the child has microcephaly. If the head circumference is more than 98 percentile, it shows that the child has microcephaly. Okay, let's take a video of growth chart.
Growth charts are a tool used by pediatricians to help track your child's physical development. There are many different types of growth charts, and in this video, we will look at the 3 most important things that you should understand. How to read the growth chart, percentiles, and trends. Number 1, how to read the growth chart. This is a growth chart for boys from birth to 36 months, looking at their length and weight. As we move from left to right, you can see your child's age in months. On this growth chart, you will see 2 parts. The top shows length, which is your child's height measured in centimeters or inches. The bottom shows your child's weight measured in kilograms or pounds. For example, this point tells us that he was 27 inches tall when he was 9 months old. Number 2, percentiles. This line is called a percentile, and it gives us an idea of how most healthy children will grow. Let's take a look at an example to better understand what this means. This child falls on the 35th percentile for height. This means that 35% of boys his age will be shorter than him. It is important to remember that a higher number does not mean better, and a lower number does not mean worse. Growth is determined by many factors, so rather than just looking at the percentile, you and your pediatrician should focus on the trend. Number 3, trends. A trend is a general direction in which something is changing. As your child grows older and your pediatrician takes more measurements, we can make an estimate of their growth. At any given visit, it is completely normal to expect your child to be a little above or below their projected growth. However, if your child's growth starts to cross multiple percentiles, this may indicate a health concern. There are many other resources available to help you keep track and understand your child's growth, including smartphone apps, handouts, and more detailed videos.
So I think that's all for me. Let's pass to the next presenter. Assalamualaikum warahmatullahi wabarakatuh. Can you guys hear me? Yes. Assalamualaikum warahmatullahi wabarakatuh. My name is Nopalena Mitumisa, meeting number 2014060. Okay, I will continue for the next procedure, which is the chest tube insertion. Okay, firstly for the introduction, what is the chest tube? Chest tube is a hollow, flexible tube which placed into the chest, which is the specific is it placed at the pleural space. The function is to drain the blood. Okay, the function is to drain the blood, fluid or air from around the lungs, heart or esophagus. And why we use the chest tube insertion? For the first one, we can use for the surgery or trauma in the chest, pneumothorax, pleural effusion, or attack in the esophagus. Next, for the indication. So for the indication, we can use the chest tube insertion in the patient who have the pneumothorax with respiratory distress. So pneumothorax is air inside the pleural space from a leak in the lung. So the chest tube will remove the air from the lung, and after removing the air, it will allow the lung to re-expand back to its normal and function well after that. And next is second one is significant pleural effusion, which is we remove the fluid inside the lung. Third one is the empyema, which we remove the pulse. Which sometimes can be due to the infection and so on. Next, for the contraindication. For the contraindication of the chest tube insertion, the first one is the pulmonary adhesion from the previous surgery, which is it was a formation of fibrotic bands that span the pleural space between the parietal and the visceral layer of the pleura. And second one is the pulmonary disease, trauma, and coagulopathy or diaphragmatic hernias. Next, let's see for the complication of the chest tube insertion. So the complication is the first one, patient may feel pain or discomfort after the chest tube insertion or during the chest tube insertion. So we will give the local anesthesia like the lidocaine to reduce the pain. Second one is infection, which is the infection can go into the lung through the tube. If we place the tube long, maybe it has the high risk to get the infection inside the lung. Third one is the leakage of air back into the pleural space, and the fourth one is bleeding, which is if the blood vessel in the skin or the chest wall may be accidentally nicked as the chest tube inserted inside the pleural space. Next is list of equipment used for the chest tube insertion, which is the suturing set, local anesthetic, like I mentioned before, like the lidocaine, underwater seal with sterile water, chest tube, which is it has appropriate size. Example for children, the size is 6 French to 26 French. And we can use also the other equipment like the suction pump, which is optional in the chest tube insertion. So let's see the methodology for the chest tube insertion. So for the first one, like the other procedure, we need the consent, and also we need to make sure the patient in a correct position. So firstly, skin will be clean using the chlorhexidine or alcohol. And next is and the local anesthetic will be injected into the skin and in the tissue along the path between the ribs. So then we will make a small incision. It's made between the mid to anterior axillary line, in between the fourth and the fifth intercostal space, tracking above the rib. So we want to avoid from the incision meet the artery or nerve, which also located between the intercostal space. Next, the chest tube is inserted and will be stitched into the space to prevent it from slipping out. And airtight sterile dressing bandage is placed over the insertion site. And the chest tube will be connected to a drainage collection device and located on the floor. And often is attached to the suction to help draw out the air or fluid. So the picture shows where we place the chest tube and the air will go through it and go to the container. Okay, next, let's see the video. Can you guys hear? No. How? Okay, I think that's all for me.
Okay, all right. So, do you have any question related to the discussion? I think most important is actually this is actually just theoretical discussion. Yeah, you must take the opportunity to observe. Of course, at least observe and if not perform, right? During on call, during your works in wards, you must be able to observe this, right? Of course, chest tube generally will be in ICU, in ICU or general ICU. Okay, the concept is the same, either adult or pediatric. Generally the same. So at least observe the adult because pediatric is quite rare. I mean, quite rare. Quite unfortunate. You're going to have to put a chest tube for a child. But in NICU, it's not uncommon, like pneumothorax, especially in ventilated baby, right? So must obtain the opportunity to observe at least one or twice. So the growth chart is a very important growth chart, especially in long case. In long case, most of the time, if you don't ask for the growth chart during the clerking, and then you didn't present it or you didn't chart it, there's a risk for you to fail the exam. So the growth chart is always available, but it's actually you need to request. You need to request the growth chart. Other presentation is quite straightforward lah. I think tak ada issue. Any other question related to the discussion? Tak ada. Alright. Okay, kalau tak ada kita end up the discussion lah. Tasbih kefaras, suara. Okay, Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam, Doktor. Thank you.